Pleasure to be here. My name's Leslie Hausmann. I'm with the University of Pittsburgh and then also the VA Pittsburgh Center for Health Equity Research and Promotion. All right, and this work was funded with generous support from the Heinz Endowment, research funding through the VA, and then also the VA Office of Health Equity. And these views are only mine and not the government. All right, so I have to say that in this current climate. All right, here we go. Testing. Awesome. All right.
Thank you.
Wonderful. Thank you, sir. Okay, so I'm going to, in my brief now 14 minutes or so, share two studies with you. One is a study that is completed and published, and we have two products. One is a case study. I don't have the QR code, but if you're interested in that PDF, you can reach me through the conference app. And then also a publication. And I'm really going to go through that quickly so I can then foreshadow some newer research that is coming out soon, hopefully. The partners in the program, you've already heard from Gilly and the prior two presentations about America Serves, which is supported by the D'Aniello Institute for Veterans and Military Family. I'm introducing the research center that I'm a part of. We are still a research center with the E word in it, at least for now, so I'm excited about that. And we specialize in research to advance the quality and equity of healthcare outcomes and healthcare services for veterans. And so what these two partners bring together is a treasure trove of outcomes data and demographic information and clinical data from the VA health record with client record data through the closed loop referral system that has been the topic of the prior couple of presentations. And all of the work that I'm talking about today is, again, building on the America Serves program, which you've already become familiar with. The main question for the first study that I'm going to be speaking about is how can VA medical centers work more effectively with community-based service organizations such as America Serves to address unmet social needs of veterans. VA medical centers care for over 6 million veterans every year. They are the largest integrated healthcare health service organization in the country, and have an abundance of services that attend to both the health needs and social needs of veterans. And so it's a natural partnership, at least in my mind, that the VA would be interested in what groups like America Serves and Combined Arms are doing, and to partner with that. But lo and behold, the extent to which the VA actually does partner with those types of organizations was not super clear before we set out to do this first study. So that was the main goal. Two sub-goals for that research question. One was to characterize the level as well as the barriers to and facilitators of participation of VA medical centers in America Serves networks. And then we also wanted to use data from the VA health record to understand what the overlapping client characteristics were and what some of the differences are between the veterans who are getting served by both America Serves and the VA, or just those who are being served by the VA. I'm going to go very quickly through this slide. For the people who like mixed methods research, we used a convergent parallel mixed method study design, starting with qualitative data collected from 7 regional American service networks. We interviewed people in leadership position as well as service delivery positions, both in the America Serves coordinating centers as well as the VA medical centers. So we really had diverse perspectives from both inside the VA and then inside the coordination centers, from leaders and people interacting with clients on a daily basis. We then also pulled together data from the client records from America Serves referral platform and developed a strategy for linking those individuals to VA health records, and that gave us a lot of information about the healthcare utilization and other risk factors that you can ascertain from the VA medical record. And then we combine these in a creative way that I'm going to get to in some of my results slides. The guiding framework underlying our design of this study was the Himmelman's developmental continuum of partnerships. That particular framework characterizes level of participation across 4 increasingly complex and formal levels. The first being networking. Networking is sort of We know about you, you know about me, here's what I'm doing, here's what you're doing, and just sort of keeping each other in the loop. Building on that, coordinating is everything that networking does, but then an added a willingness and ability to start tailoring what you're doing to better coalesce with what the other organization is doing. Cooperating, again, all of the previous attributes, but then also starting to be more proactive about sharing resources, responsibilities, risks and rewards, and really seeing more compromising and adaptation at that cooperating stage. And then finally, collaborating is the most high level of partnership, and it's all of the above, and then also the types of sharing risks and responsibilities and tailoring of activities really is to try to help your partner do what they do best in an even better way than if the partnership did not exist. So as you might ascertain from the descriptions of these, the networking starts at a very low level of formality. It doesn't require a lot of intensity, and it doesn't really require a lot of time or trust to achieve networking. And as you move up the steps, it does increase formality and intensity and level of trust. Okay, so we interviewed people in 7 different America Serves networks, and I'm going to share with you where those 7 networks landed. And I'm calling them the networks, but it's really the VA and the networks combined. So out of the 7 that we focused on, 3 were in that networking level. Another 2 were at coordinating, so over half of the 7 were in those first 2 levels. And then we had 1 each at cooperating and 1 each in collaborating. So we had the full range of participation, but it definitely skewed towards the more informal and lower levels of intensity. Here's where the mixed methods part comes in. So what you're seeing here is in the gray bar, the overall resolution rate. This is based on client data from America Serves, and we defined resolution rate in this study as the likelihood that the service request was delivered and closed. We don't have any real qualitative data about how effective the service was or whatnot, but it was definitely, the person wasn't lost to follow-up, it was a closed case. And you can see in the networking, just focusing on that gray bar still, you do see an increase as you go from networking all the way up to cooperating and collaborating, with the resolution rate being 65 on one end of the spectrum and then the mid to high 80s on the other end. The other 2, or the 3 lower rows are, let's see, I do have this, don't I? So the America Serves only clients and dually served clients, we wanted to see if there was a signal about are the resolution rates different for people who are being served by both systems or just America Serves in this case. And what you could see in networking, it was a dead heat. And then as you go even just up 1 level of participation intensity, you do start to see a divergence in that the dually served clients, these are the veterans who are getting care from both systems, tend to have a better resolution rate when it comes to the services they're requesting through America Serves. Some other data that we were able to ascertain from this study was what do the dually served clients look like compared to the general veteran population being served in VA medical centers. This is very important when you consider that the social service sector often is not getting reimbursed, and the healthcare system may be benefiting from that partnership in ways by reduced cost, especially given that VA is an integrated healthcare system and is a provider and payer. And what you see here, I'll just call your attention to, call your attention to the take-home messages in the right there. Compared to the general VA medical center population in the region served, we had significantly younger patients in the dually served population, quite a few more women, proportionally speaking, more Hispanic and Black veterans, and then also more documented social needs and risks in VA health records. And everything from this line on down is evidence that you can get from the VA records that there are some complex needs that are being met. All right, so the past research summary is that America Serves networks have a range of relationships with VA medical centers. Those with stronger relationships have higher case resolution rates, especially for the dually served veterans. And then also the veterans that are served by America Serves as well as the VA are high risk and have more complex needs than the general VA population. So fast forward to today, and we are in year 2 of a 3-year study where we are seeking to answer the question, how does receiving support from one America Serves network, specifically PA Serves, affect the receipt of benefits, VHA healthcare use, and VHA healthcare costs? So very briefly, PA Serves is the America Serves coordinated network operating in Western Pennsylvania. It is run by the Veterans Leadership Program with its fearless leader right over there. And PA Serves is the second most active America Serves network and has had very strong relationships with the VA medical centers in our region as well as the Veterans Benefits Office in our region, and that sort of strong partnership as well as the high volume was why we selected PA Serves for this next study. This is a complex model. I'll just very briefly point out a few things. You know, we recognize that veterans come into PA Serves for a whole bunch of different reasons. They can also enter into PA Serves through any number of channels because this is a no wrong door situation where the veteran can self-refer. They can go to the VA healthcare setting and there may be something that a social worker says, hey, PA Serves may be able to help you with this because the VA cannot. Veterans Benefits may have a similar situation, as well as if any of the participating social service providers can send veterans into the network. And then where they go also is completely tailored to the individual needs of the veterans, and they can end up going to VBA, Veterans Benefits, VHA, Veterans Healthcare, any other social service provider. And what we're testing in this study is we are going to just describe what are the types of services that everybody is getting out of these various channels. And then our hypotheses really focus on what happens to the VHA healthcare utilization after their initial encounter with PA Serves. And then also a related question is how does not only utilization change, but then also what is the cost impact of those changes? So we are still early, and building a cohort takes forever. And so we have our exposure cohort, which I'm super excited about, and we're like this close to having our comparison cohort ready to go. So the people who are going to be in the main analyses, we, after applying several inclusion and exclusion criteria, we have arrived on 1,954 clients who had a whopping 8,373 service episodes. So this is our population that we're going to be learning a lot about over the next year and a half. And then I was also able to share with you today some cohort demographics, which very much mirror the patterns that we found with the prior study using more America Serves networks. And so things to note here is that women veterans are overrepresented relative to the overall veteran population. So in the general population in or nationally, it was about 11.3% of women. We had 15%, have 15% in our sample. Black and African American veterans are also represented relative to what we have with that population in our region. And then also, for those of you who are familiar with the Area Deprivation Index, it's an indicator, or maybe those not familiar with this index, it's an indicator of the economic vitality of the neighborhoods in which veterans live. And we have over 20% of our sample is living in the most deprived areas. And so it really shouldn't be that high. And so we are very much serving, or going to be studying a high need, high risk population. And then here, 82% of the cohort had a VHA healthcare encounter in the 24 months prior to the PA Serves exposure. What that is going to give us is we do have some people who will be new to the VA because of their exposure. So we're going to be able to see what, those people who didn't come to the VA before, what kind of services are they using as a result of their PA Serves support, or after, that is. And then finally, substantial social risks are also being documented in the VA record. A lot of housing insecurity, justice involvement, and so forth. So yet to come, we're finalizing our comparison cohort and developing propensity weights and hypothesis testing. And with that, my time is up. All right.